Hello, thanks for coming. Ruth Myers here. For this next seminar, I thought maybe we'd talk about schizophrenia, schizoaffective disorder, and bipolar disorder. A lot of the people we care about deal with these conditions, and maybe we can learn a little more about them, how they're recognized, and more importantly, I think to all of us, is everyday ways to help the person who has this condition. So can the presentation of schizophrenia be kind of subtle? We talked about this in one of the other seminars, the statement of Ruth, he's doing it again. Well, what's that? The inappropriate coffee behavior. You know, it doesn't sound all that dramatic right up front, but sure enough, this is a man where he starts by very, very subtly taking the pot of coffee that he likes to have staff prepare for him, taking it outside, pouring it out on the ground, coming back in, and remaking the identical pot of coffee for himself. Now, on the surface, that doesn't mean much of anything, does it? But in fact, people that know him know that this is the beginning of the type of paranoia for him that, as it gets worse and worse, makes it so that he doesn't even want to eat food that anybody else has touched or breathed on. And it's made him very, very ill in the past, and is typically therefore a signal that the schizophrenia that he copes with has been triggered and worsened, and he needs some kind of adjustment in his treatment. Well, maybe some of you have already heard, what exactly does the word schizophrenia mean? Years ago, people used to say, that means a rupturing of the personality. Some people misunderstood that to mean a split personality. What it really means, that schism, is that the person with schizophrenia has thoughts that are partly in the sort of readily acknowledged real world, and then part of their thoughts are in a world not evident to others, different from ordinary daydreaming. Daydreaming is something a person can start and stop, whereas people with schizophrenia typically report they really don't have that much control over these sensations. And in a minute, we'll talk about, well, what exactly does a hallucination feel like for those of you that may have not experienced one in your lifetime. What are the standard psychiatric criteria for schizophrenia? This is important because not every psychosis, not every hallucination or delusion is a part of schizophrenia. In fact, only a minority of people with psychosis have schizophrenia if they have a developmental disability. That's a discussion for another day about how so many other conditions can cause people to have hallucinations and delusions. But for people to meet the criteria for schizophrenia, they have two or more of the following for a significant period of time. I think that for most people that have these symptoms, pretty much any time feels pretty significant, but however that's interpreted. Delusions. What's a delusion? We'll talk about that. Hallucination, disorganized speech. There's an old term called word salad, where a person just says a whole bunch of words that don't have anything to do with each other. Grossly disorganized, and those are the people that are all busy doing all kinds of aimless movements, but they're not tics, it's not Tourette's syndrome, it's disorganized behavior. Or catatonia, where they have no behavior. They're frozen in place. Or what's called negative symptoms, which is a type of particularly intense social withdrawal and lack of initiation of activities. Social and occupational dysfunction due to the condition, and that's a very subjective thing. You know, some people walk around with a lot of hallucinations a lot of the time, and it's not a big deal to them. They'd rather have more hallucinations and less medication, and it doesn't get in their way that much. But for other people, it can be pretty life-changing. It's not due just to a mood disorder, not due to some other health problem. That's the other lecture and seminar that I alluded to. Needs to go on for at least about 6 months. Not due to substance abuse or misuse, which is a bigger and bigger issue as more people experiment with more kinds of sort of unpredictable chemicals that can very definitely simulate all the symptoms of schizophrenia. So what exactly is a negative symptom? Negative symptoms of schizophrenia don't get that much attention, but many people feel like they're actually, in many ways, more painful than the more obvious symptoms of hallucinations and delusions. Affective flattening, people whose face just doesn't seem to show much. Avolition, very hard time starting to do anything, being almost sort of glued in place. Alogia, same thing, having to do with communication, just really hesitant and sometimes unwilling, very hesitant, very inhibited in terms of communication, even when the person would like to communicate. And a sort of apparent disinterest in other people. There's a kind of a broader understanding of that finding, though. I think that some people feel that it's not so much disinterest as being easily overwhelmed. Some people with schizophrenia will describe the presence of another person as so intense that it's very hard to sustain. Similar in some ways to the way some people with autism describe contact with other people. If the person also has autism or pervasive developmental disorder, they have to have hallucinations or delusions to be diagnosed with schizophrenia because there's so much otherwise overlap in the apparent symptoms. A lot is written about how incapacitating these conditions are, and that's absolutely true. There's also a lot made of, but now we've got the modern drugs and that'll fix everything. But people have been coping successfully with these conditions for a long, long time. Some more successfully than others. Some have been offered every kind of treatment and refused and had a disastrous outcome. Some had a fabulous outcome. For example, we'll have famous people visit us throughout the discussion. Anybody remember who this is? John Hinckley Jr. He was going to impress a famous movie actress by assassinating. Now, only in the mind of a person with schizophrenia or certain subtypes of bipolar disorder would you think that's the way to a person's heart. But in fact, that is exactly how he formulated it and why he made the assassination attempt that he did. There's a bunch of different subtypes of schizophrenia. The paranoid subtype is hallucinations where the person is being targeted and persecuted. Delusions, not necessarily associated with the disorganized speech or catatonia. Can a person with schizophrenia have more than one type of schizophrenia? Oh my, yes. Catatonic schizophrenia is particularly intriguing because although it used to be considered an absolute classic symptom of schizophrenia, in fact, it's a symptom of a whole lot of other neurophysiologic conditions and endocrine conditions. So even when a person looks for all the world like they have catatonic schizophrenia, if they're not doing well fairly quickly with proper treatment of schizophrenia, we probably need to go on the hunt for other possible causes. Disorganized schizophrenia it involves the people that have the incoherent speech and the behavior that doesn't make much sense. And one of the best lessons I ever learned when I was in training in a state psychiatric hospital was, this was back a number of years ago when people were in the hospital long enough to where it made sense for them to have passes to see if the treatment was working well enough for them to be discharged. Unfortunately, people get discharged within a matter of hours or a couple days now, whereas in the past we had a little bit more time to kind of work with a person. Well, anyway, there was this one fellow that came on the unit, and he was very, very well-known to the unit because every time his medicine was interrupted, and it was typically not his fault, as a matter of fact, long story for another day, he became extremely disorganized. It didn't make any sense, and his speech had this sort of word salad composition, but it had the rhythm of Shakespeare. So people, other staff members, kind of messed with him. They played with him in a not very nice way. Hey, Shakespeare. Kind of made fun of him for the way he was talking. And me being a brand new newbie, I'm saying, that doesn't feel right to me. Oh, he doesn't remember any of it. It won't hurt him at all. Okay. Well, after the medicine started to work, and it takes most medicines 3 or 4 days to start working, he went on a pass and he came back with a stuffed clown, a toy, a stuffed clown. And he gave it to me. I said, oh, this is very sweet. Well, why is this? And he said, because when I was really sick, you didn't treat me like a clown. You can imagine, I have held on to that. What an important lesson. There's nothing funny or amusing about having schizophrenia and being ill with it, is there? Undifferentiated schizophrenia is a person with prominent hallucinations and delusions, but without the paranoia, catatonia, or disorganization. And residual type is a person who still has, for example, negative symptoms or disengagement with their surroundings, but they don't have overt hallucinations and delusions, but they still have very eccentric, unusual engagement with their world. All right, everybody remember who this is? Remember the movie Shine? This is David Hilfgott, an incredibly gifted pianist who happened to have schizophrenia, but he could organize himself around music and give these brilliant performances when otherwise he could barely function due to the seriousness of the mental illness. He teaches us that if there is something that a given person with schizophrenia finds to be organizing, if we're to help, we need to make sure that's available all the time, and certainly not something to leverage. Well, he needs to earn his time on the computer. No. If the computer organizes him, we need to have that available all the time. I just saw a man in a consultation where the only time he didn't have hallucinations was when he was deep in certain video games. And his family just was absolutely stuck on this idea that the video games were causing the schizophrenia. And he needs to have that stopped. Even though the more hours on video, the less he had hallucinations. And finally, they snatched away his electronics, and he ended up back in the hospital in a very, very, very serious state of deterioration. The most dramatic symptoms of schizophrenia is psychosis, the hallucinations, the delusions, what have you, but it's not necessarily the most disabling part of it. Everybody recognize this dude? You probably last saw him when he was about this high, and he was playing the very, very young Anakin Skywalker in the second set of Star Wars movies. This is Jake Lloyd, who withdrew from acting after he developed schizophrenia. Apparently, I'm told he's doing fairly well, but he was very, very ill. And incapacitated for a good period of time. I'll just mention, let's talk a little bit about those hallucinations. I'll just mention, and we looked at this in another seminar, there are ways to recognize hallucinations and delusions in people that communicate without speech. And for details, we'll spend some time in the other seminar going over that. Just to be clear on what psychosis is, people will use sort of a colloquial, oh man, that's psychotic. That's not very precise. What psychosis means is a distortion in thinking that is very specific to either hallucinations, delusions, or paranoia. Well, what's a hallucination? This is a sensory distortion. Auditory hallucination is sounds that are not evident to others and not accounted for by auditory hyperacusis. People that are in an absolutely quiet, empty room and are hearing crowds of people yelling at them. It could be people that they know, although that sort of hallucination is more consistent with post-traumatic stress disorder, or it could more commonly be people that they don't recognize, unfamiliar voices, male, female, or neutral, that might be talking about neutral topics, might be mean, might be encouraging and nice, might be scary, might be reassuring. Visual hallucinations, right? Either distortions of real things. A person looks at a plate of spaghetti and sees a whole bunch of writhing bugs. That's an example of a type of visual hallucination. Or seeing things that are not evident to others. The hallucinations can range from vague outlines to fully formed three-dimensional objects, animals, and people. Olfactory hallucinations are odors that don't conform to the person's surroundings. Sometimes those odors are related to memory, so it's post-trauma or positive memories. Sometimes those odors are manufactured from psychosis per se. Gustatory hallucinations, tastes, flavors that are not associated with anything the person's put in their mouth. Tactile hallucinations are a sensation that something's on the person. Delusions are false beliefs, out of the range of possibility, not consistent with culture, and they produce distress, dysfunction, or unsafe behavior. Examples of this would be people that go to the 35th floor and are quite sure that if they just wave their arms hard enough, they can fly without any form of equipment. That's an example of a dangerous delusion. Some of the more horrifying dangerous delusions are involved in postpartum psychosis, where the new mother is convinced that the only way to save her child is to kill it. That's unfortunately a horrible and not unheard of postpartum delusion in people that develop postpartum psychosis. What are culturally appropriate delusions? Well, we can't call them delusions, but culturally appropriate beliefs usually have to do with religious beliefs, relationships with people that are deceased, and similar types of, again, spiritual or religious phenomena that need to be respected, not medicated. All right, we all know this guy, right? Charles Manson did all those horrible things. Charles Manson did have schizophrenia. The question is, was that the reason he killed all those people or had them killed? The answer is no. He had schizophrenia. That wasn't the problem. The problem was that he was a sociopath as well. He liked hurting people. That's very, very important. Schizophrenia does not increase the risk of danger. It's other stuff compounding schizophrenia that may cause the person with schizophrenia to become violent. The issue of the person having delusions that drive them to violence is really, really, really uncommon. And Manson is a very good example of somebody where, yep, he had schizophrenia, but that wasn't the reason for all the horrible things he did. Paranoia is the belief that others think ill of you and are scheming against you. And it's out of the realm of possibility. I had one lady I worked with for years and years and years, and she had what we call a fixed delusion. Nothing could shake it. She had a very particularly incapacitating form of rheumatoid arthritis. You've probably seen people where every visible joint is really tremendously distorted and very, very hard for any kind of movement or purposeful activity. Despite that not subtle disabling condition, she was quite sure the FBI was surveilling her at all times, trying to find reasons to have her disability benefits removed. Now, it didn't help her much when I explained that the FBI doesn't get involved in that, disability fraud. That's other people. No, I didn't get into that. It was a fixed delusion. And she didn't want to take any more medicine than she was already on. And she just worked around it. That is a fixed paranoid delusion. It's felt to be in the realm of psychosis when the others are people that don't know the person or are very, very unlikely to have any interest in that person's life. Reassuring the person typically makes them feel worse. Oh, you're in on it. So, what do we talk about? People with schizophrenia who did some pretty fabulous things even in the times when there was no medicine to treat schizophrenia. How about Clara Bow? One of the most successful and amazing actresses of the silent film era. She had schizophrenia. She managed it. And she had a successful career as an actress. What an amazing face, huh? What are some blended hallucinations and delusions? Ideas of reference, where the person feels like they're getting specific instructions from the TV or the radio that are specific to them. Thought insertion is the thing where a person feels like passersby are putting thoughts in their head. I worked with one man, and you never know what might be soothing. I worked with one man who said that the only time people didn't put thoughts in his head was if he put aluminum foil over his windows in his house and in his car. Okay. Are we going to give him a hard time because that's kind of eccentric? And by the way, he didn't need the foil on the windshield, just the side windows. Are we going to give him a bad time about that? Are we going to point out the logical inconsistencies in his? No. That's such a harmless way to manage a really painful symptom. And that goes to what we're going to talk about in terms of everyday ways to help. Thought broadcasting, similarly, the person believes that other people are hearing their thoughts. And typically, they don't think people are hearing them compassionately. And Capgras phenomena, the delusion of substitutions. I had one fellow with schizophrenia that he referred to this as the L switcheroo. Well, Ruth, I got home and I had the Capgras with the L switcheroo, where he believed that all of his possessions had been removed and replaced with nearly perfect copies. This can also refer to people. The person who suddenly believes they have 3 sets of parents, but only like one of them, for example. What are some screening questions? If you're thinking, well, this person, I'm wondering if they've got some hallucinations or they've had them. These are basic screening questions, and none of these by themselves make a diagnosis. They can just help guide us in our observations. Do you have dreams at night? Most people know what that means. Do you have dreams during the day when you're awake? That is one way that people describe hallucinations. It's like you're in a dream, only it's during the day. And you know how sometimes at night you think a dream is real and it scares you, and other times a dream doesn't feel that real and it doesn't bother you that much? That's what hallucinations of schizophrenia feel like. Does it ever seem like the air is talking to you? Do you ever see ghosts? Do the walls or carpets ever start to move or make noise? One man I knew with schizophrenia, his one very isolated and kind of scary symptom was when his meds were out of balance, he would start to see all the carpets and the walls have eyes staring at him, blinking at him. That sounded really scary. He said, well, you know, Ruth, I found that to be kind of scary. I'll bet you did. Holy buckets. Do you ever feel like something's on you and there's nothing there? Getting to tactile hallucinations. Do the voices or the ghosts ever touch you? Do they ever smell funny? Do they ever get a bad smell? Do people fart a lot around you? Do you ever get a nasty taste in your mouth and there's no good reason for it? Do you ever feel like you got to spit something out and there's nothing there? Ways, plain language ways to help people tell the story. Does it ever seem like strangers are kind of trying to mess with you or stare at you? Wow. Does it ever look like something's getting put in your food? Or does your food taste funny to you? Anybody remember who this is? Absolutely fabulously brilliant mathematician. I think Russell Crowe got an Oscar for playing him. John Nash, stupendous, brilliant mathematician who had schizophrenia. And very, very hard with some of the people that are creative geniuses who also have schizophrenia. And we'll talk about why in a second. Recognize this lady in the era before any kind of medications were possible? You might know her as Daisy, Zelda Fitzgerald, F. Scott Fitzgerald's wife, who had schizophrenia and had a pretty miserable time with it, as did he. So if a person's in your presence and they have severe paranoia or other psychosis or just have tremendous issues trusting you for all kinds of reasons, often not having a thing to do with you, open and shared charting, I think, is one of the most useful tools we can have. You know, anything I write, you can see, you can edit, you can correct. When a person starts to tell me something that I'm 108% sure must be a delusion or a description of a hallucination, I don't start cross-examining them or arguing with them. I just tell them to keep describing it and telling me the details and tell me more. Even the act of having somebody listen without arguing can be helpful. I know I've heard other people say, well, doesn't it seem then that you're like agreeing with the delusion? And I would say that people don't assume that unless they ask you and you say you agree. And when somebody says, Ruth, does this sound crazy? I'm not going to say, oh no, that sounds real. And I'm not going to say, yeah, it sounds very distorted. What I'm going to say is, I don't know. Keep telling me about it, and we can figure it out together. There's usually a person or two that the individual can trust. They should always have access to that person. Your act of making sure they can always be in touch with the person they trust makes you more trustworthy. Yeah, I got nothing to hide. Yeah, call her right now. Can I dial for you? Over-inform. Give people way, way more information than they want until they tell you to quit it. It's one of the few ways you can maybe convince people you're not hiding anything from them. Don't take the distrust personally. And I'm sure you found other ways. And when you find a good way to develop some trust with an individual we support, don't keep it a secret. Be sure and share with the rest of the circle so that the person can expand their network of people they feel comfortable with. Now, Karen was 33 years old, and she was referred for, this sure sounds like schizophrenia to us, because she would stare over at the walls and she would kind of nod and, look like there was some communication going on there. She also pushed people away when they got near her, and she had inappropriate candy stealing. I always roll my eyes at that kind of a description. But she was actually not just a burglar, she was an artist. If you had a piece of a certain type of candy in the trunk of your car, she would find it. And it was always these really strong tasting, like Red Hots or Altoids, some of those really intense tasting candies. And that was her jam. And my thought was, well, why can't she just have some with her all the time? What? Isn't that giving in to the inappropriate behavior? I'm like, oh, please. So we visit for a while. And she did that thing where she was kind of like squeezing her eyes shut, looking off like that, pushing people away when they got close. And I said, what's her vision like? And so we checked with her sister. Oh yeah, she's got really, really terrible nearsightedness. And we're pretty sure she'd never wear glasses. We believe she'll never wear glasses? What? Oh my goodness. So I handed her my glasses. She put them on. Her prescription is undoubtedly different than mine, but she never took them off. She didn't break them, she didn't do anything with them until she got glasses of her own. Okay, so this looking like she's hallucinating was really just because she couldn't see anything, and people would come out of the blur and startle her. Well, what about this candy business? Well, it's an inappropriate candy obsession, we're sure. And I thought, well, that's possible. Such things are possible. What else do we know about this woman? Well, her sister, the art therapist, said, there is that thing that happened with that other agency. What thing was that? Well, and also the other thing that I should mention is that if she didn't get the candy when she wanted it, she tended to start howling and shrieking and banging her head and pulling out her hair. Okay, so this is important. Her sister said, well, you know what happened to her, right? The staff there stuck in a bite guard and forced her to perform oral sex on them. Obviously, those intense candies were fighting back that flashback, weren't they? So she did get access to all the intense tasting candy she ever wanted, and she also got proper art psychotherapy to recover from this abuse. And eventually didn't need that support all the time. She almost never, after the first year or so of proper treatment, it got so she wasn't having that flashback. Very important. I mention her because originally she was billed as, well, this is some kind of schizophrenia, obviously, when in fact it was two entirely separate problems that had nothing to do with schizophrenia. And if we'd gone down the road of, well, let's try one schizophrenia drug after another, I don't think we would have ended up in such a good place. Schizophrenia, as opposed to other psychiatric conditions or other conditions that cause hallucinations, has a few absolutely unique features. Difficulties with initiation is one of them. People with schizophrenia, neurologically speaking, have a hard time initiating activities, often need encouragement. It's not being resistant, it's neurology. The big thing that I cannot emphasize enough is that there is an issue of sensory gating abnormalities. What you probably know is that sensory gating is a function of the brain where, without having to think about it, people automatically sort and prioritize incoming information. So if a person has typical, ordinary sensory gating, and they're sitting in this room, they are able to concentrate on one thing, whether it's the temperature, the sound of the projector, the light, or even maybe what I'm talking about. And their brain automatically, again, without extra effort, deprioritizes everything else. In people with schizophrenia, people who are acutely psychotic for other reasons, and in first-degree family members of people with schizophrenia, that capacity to sort and prioritize stimuli is impaired or completely absent, which means that at all times, for a person with schizophrenia, everything's coming in at the same intensity. The sound, the temperature, the sights, the other sensations, it's all coming in at the same time. So if you have schizophrenia, it's an act of will to focus on this and ignore this. That's tiring. And that, to me, is one of the main reasons why most people with schizophrenia have a certain tolerance, and then they need to be allowed to be alone. Because the only way, once that's overrun, the only way to get relief is to be in a situation where the sensory input is down to near nothing. So it's been my observation, and maybe it's yours too, that when people with schizophrenia say, "Get away from me, I need to be alone," it's not because they don't care or they're antisocial. It's because they've overrun their capacity for voluntary sensory gating. The other classic feature of people with schizophrenia that can be often misinterpreted is that affect, the person's facial expressions and emotional expressions, may be quite different than the content of what they're experiencing. The classic case, and I have a few videos of people that are talking about topics like dismemberment and torture, and they're kind of giggling and laughing while they're talking about it. It's not because they're enjoying it. It's because their brain is wired that way to react differently than what they might really be feeling. And that certainly can be misinterpreted. One of the ways to kind of gauge a person's sensory gating is what I call the favorite activity test. What is it that this person likes to do that's in kind of a loud, stimulating environment? Sporting events, the state fair, shopping malls, whatever they like. And however long they can tolerate that without saying, without getting that look and without starting to get confused and need to leave, that's probably how much sensory gating they can manage on their own without extra help, without having to leave the situation. Now, once the gating is overrun, a lot of that input starts to get mishmashed. And that is felt to be one of the mechanisms by which hallucinations are generated. Well, how do antipsychotic medications work? They don't fix this gating thing. They basically blunt incoming stimulation so that people just don't have as much incoming to resist. That's how they're made. But that is also the reason why if a person doesn't have a gating abnormality, but they have some other reason for being hypersensitive, ongoing use of antipsychotic medication in fact blunts their capacity to learn. Which is why I think one of the main reasons why there's so much resistance to using antipsychotic medications for everything under the sun, whether or not there's any hallucinations or delusions involved. There is one drug only, that reverses sensory gating abnormalities. One drug. And it only does so, with each dose, it only does so for a fraction of a second. But the people that are tracking it say that the relief is exquisite. Would you like to guess what that one drug is that can cause people to have clarity that they never get the rest of the time? Yep, I bet many of you have guessed. It's inhaled tobacco smoke. Not nicotine patches, not nicotine pills, but inhaled tobacco smoke. I've watched this done. You can measure the waveforms on certain types of EEG monitoring. And you see the person with this very, very distorted gating wave because it's not functioning. And the wave normalizes for just a fraction of a second each time the person takes a drag on a cigarette. Some people guess that might be part of the reason why so many people with schizophrenia have an addiction to cigarettes. Some people guess that might be the reason. And for some people with schizophrenia, although obviously the health risks of cigarette smoking are well defined, I've met many people with schizophrenia where a few cigarettes a day means a whole lot less antipsychotic medication a day, and they feel better. And sometimes I think, oh, for goodness sake, go ahead and smoke. The other thing I'll mention is that antipsychotic medications were not universally beloved by people with schizophrenia. People who'd been having active hallucinations for decades suddenly found themselves feeling very lonely when those hallucinations went away. And in fact, it may have been medication side effects, but it might have been something else. On the wards where everybody got big, gigantic doses of chlorpromazine, which was the first antipsychotic medication, and the hallucinations went away, suicide rates went up 200%. It's not as simple as just making them go away, is it? What else besides schizophrenia can produce hallucinations, delusions, and paranoia? A whole bunch of stuff. And you can definitely read through this list anytime you want. We talk about all of these things in more detail in some of the other seminars. I want to point out extreme overwhelming stress, which can cause a phenomenon called a brief reactive psychosis. And I want to point out sleep deprivation. Both of these conditions occur much more often in the lives of people with intellectual and developmental disabilities. There's some over-the-counter medications that can cause people to have all the same symptoms as schizophrenia. Phenylpropanolamine is still found in some diet pills and decongestants. Zantac, Pepcid, Axid, Tagamet, which are H2 blockers. High-dose antihistamines, so people that take 4 Benadryls at night to try and sleep may end up with some pretty severe hallucinations and delusions. In addition, if a person already has a schizophreniform disorder, taking these conditions may magnify it. So, anybody remember this guy? He believed that by mentoring wrestlers, they in fact became his property and his servants. And he became so ill and distorted in his thinking that he shot and killed one. This is John DuPont, who thought that being rich, his family, I guess, thought that being rich meant that he was immunized against needing treatment for his very obvious and very severe and unfortunately very lethal type of schizophrenia. These are some prescribed medicines that can cause hallucinations. And again, some frequent flyers on this list to be aware of: stimulants, steroids, certain heart medications like amiodarone, some sleeping medicines, particularly Halcion and Ambien, Dilantin, and a whole bunch of other ones. The thing to keep in mind is that if a person starts to have a worsening of hallucinations or new onset hallucinations, well, let's first take a look at their med list. And we can sometimes find stuff. So we've kind of demonstrated over the last 40, 50 years or so that a great majority of people with schizophrenia can recover and do very well. What seems to get in the way for those who don't recover? Well, some people have just a particularly severe form of schizophrenia, but for the most part, it's other stuff. And to not be too distracted by schizophrenia and look for the other stuff can really help a person. So crappy living conditions, boredom is especially lethally toxic to people with schizophrenia. Inflexible, noisy living or working situations. In fact, the worst possible daytime situation for a person with schizophrenia is a big, loud, noisy, sheltered workshop for people with schizophrenia. Highly critical, significant others. Those people that cannot help themselves, they have to be giving advice and guidance, air quotes, guidance all day long. It's just gratuitous criticism, and every bit of it, every needle worsens the person with schizophrenia. This was a horrifying statistic that I just learned in my most recent Harvard psychiatry course. The life expectancy of persons with schizophrenia as compared to the general population is 20 years lower. Why is it? Is it something to do with schizophrenia? Does schizophrenia affect the rest of a person's body? And the answer is no. It's because those doctors that don't deal with psychiatry they don't like giving care to people with schizophrenia. It says, I'm sending you to somebody who's less squeamish. Unfortunately, doctors in other specialties, and even many doctors who are psychiatrists, have a hard time being around people with schizophrenia. Don't understand why, but that withholding of health care is felt to be the reason that people with schizophrenia die so much younger than other people. It's not lifestyle, it's not anything other than not getting treated for their lung problems, heart problems, blood pressure, diabetes, and so on. At least that's what the evidence is suggesting now. Common misconceptions, rumor mill myths that are just wrong about people with schizophrenia. There's still some people that think that everybody with schizophrenia deteriorates and dements and loses function. It's just not the case. There's still an idea that people with schizophrenia can't live independently. And when I had my private practice in Minnesota, I had a whole bunch of patients who were people with schizophrenia who had like spouses and jobs and children and families and lives. And they came to me as an individual solo practitioner because almost everybody they met in the larger clinics assumed that they must be in a board and care home needing 24-hour support from paid staff. And they just didn't like having to re-explain that over and over again. There's a common misconception that people with schizophrenia are dangerous. They're less dangerous as a group than most people. And there's a couple of ideas that you can't recover unless you always take medicine. That's not really true. And there's an idea that if you have a lot of hallucinations and delusions, that means you have bad judgment. It's not true either. People with schizophrenia can often have a lot of psychosis going on and still exercise pretty good judgment in their lives. Medications are not always necessary, but there's also a school of thought that says early treatment with medications may in fact make the course of schizophrenia easier for a given individual. So there's a lot of back and forth. Some people say, well, that early treatment, that early management may or may not include medicines. Other people believe that medicines are the absolute cornerstone foundation of treatment. And I think it comes back to, just like we've said about everything else, each individual person. Antipsychotics, there's first generation medicines, they're still pretty helpful. You know, the Haldol, Stelazine, Trilofan group. Then there's the second generation medicines, and it was really funny because I'm old enough to remember when they were brand new, and everybody assumed they'd have no side effects just because they were different. Not true, right? They're just different in their incredibly serious long-term side effects. And then there's clozapine, which is the most potent medicine we have for treatment of schizophrenia. There's injected long-acting medicines. Sometimes a person can have a shot and get relief for 3 or 6 months. And then there's mixed action medicines that are blended antipsychotic, antidepressant. And they're variably effective depending on the person. How long does it take for an antipsychotic medication to relieve hallucinations? Most people think it's immediate because they get so much of it injected in emergency rooms. In fact, what happens is if a person gets an injection of Haldol, whatever, olanzapine, they're sedated, but the hallucinations don't go away. It takes usually 3 days or so for the hallucinations to decline in response to a dose of antipsychotic medication. There is one antipsychotic medication that relieves hallucinations immediately. It's called asenapine, and it's given under the person's tongue. The brand name is Saffris, and right now this is the only medicine we have that in fact relieves hallucinations immediately. And I do not understand why it isn't used more often in emergency situations, because it actually is kind of minimal in terms of side effects. Gets into his person's system immediately when it's given under the tongue. Doesn't have to be injected. Can be put on as a film, as a patch, and works right away to relieve those especially terrifying symptoms. It's not even that new, so I don't know. Other medicines that are used to amplify the benefits of antipsychotic medications, low-dose lithium, other mood stabilizers. In emergency situations, it's felt that relief of anxiety helps reduce the impact of terrifying hallucinations, so some people will get anti-anxiety medicines. And we're all over the place in terms of cannabis. Because keep in mind, cannabis is a hallucinogen. And it used to be 100% no way, never, ever, ever should people with schizophrenia be fooling around with cannabis. But some very, very smart people have invented some extracts of cannabis that many people with schizophrenia find to be very helpful. Not necessarily in eliminating or reducing hallucinations, but eliminating or reducing the fear associated with them. Still, the jury's out. We're not entirely sure yet, but can't rule it out. It's a medicine that people have been cultivating and using for centuries, so who knows? There might be something to it after all. People have personal coping strategies. Private time is the most common one. Sensory flooding or absolute quiet. Self-protection, testing other people, pets, pet-assisted supports. And some people will have a word ritual that helps them. I had one man, he had the most severe disorganized schizophrenia I'd ever seen in his life. In his life, my life, or any life, he's just incredibly disorganized. However, if you say, hey, Larry, presidents? George Washington was president of the United States he could recite every president, their dates in office, and their vice president, and sometimes their spouses, through all of U.S. history. And as soon as he started reciting that, it's like his whole brain would relax in front of your eyes. His expression would clear, he'd start to look calm, and then he could engage with his life again. Why the presidents? Everybody respects it. So, everyday ways to help a person with schizophrenia. Quiet, peaceful living situation. No noisy, unpredictable housemates, unless they're the person's best friend and know the rules about backing off when it's appropriate. Predictable structure that's also flexible. And some people have a hard time knowing how to do that at the same time. Predictable is, well, I'll be making some hot breakfast between 7 and 9 if you'd like it. But if you don't want that at that time, we can do it another time. So the person knows if they come to the kitchen at 8 a.m., they can get a hot breakfast and not have to ask for it. But they can also say, not today, I'll take that at 11. It's a very hard switch for people that are used to trying to regiment people. Obviously, make available anything that helps organize a person's thinking. Like the kid I told you about who uses video games and virtual reality to organize himself. Should have that available at all times until we can come up with a better option for him, right? Avoid interfering with security rituals. The aluminum foil on the windows, the special extra locks on the door, whatever it is. If it helps, it helps. There's no reason to fight with a person about it. Don't argue with the delusions unless the person asks for your opinion. If the person is acting on delusions in unsafe ways, then attention from a mental health professional should be obtained, and stalling with the person in the meantime. So you're thinking you can jump off this building and fly without any wings or anything? Well, maybe I should come with you while you do that. That I'm not sure about that. Let's check this out together. Basically stalling until you can get proper support and maybe talk the person into something else. Also, really important that the person have unlimited access to anything they love to do. Again, another situation where asking people to earn their favorite activities is a terrible idea. And be careful with humor. When a person has schizophrenia, particularly paranoia, what you think is funny may land totally differently. So just be aware. Let the other person take the lead with humor. The other thing to keep in mind is just how incredibly sadistic and capricious these diseases can be. This one gal, I worked with her for 15 years, and she called herself Sally Schizophrenia. She said, yeah, I'm one of those schizophrenics, all right. After almost 15 years, it was like 12 years, I moved to a different state and wished her well. We kept in touch. She let me know how life was. You're the best doctor ever. You were great. And then all of a sudden, I got this enraged phone call. A year or two later, nothing had changed. Her life was still good. Her medicines were still right. She wasn't, misusing substances or anything like that. She just called and said, I hate you. You are the worst person ever. You forced me to gamble. You forced me to lose all my money. You need to pay my gambling debts. I'd asked her every single time we met, any habits, out of control, gambling, anything like that? No, everything's fine. But her illness caused her to think that I should have been reading her mind to know that she was getting into trouble with gambling. That's what her illness told her. That Ruth, she should have been able to read your mind. Even though you said no, she should have known. And these diseases are so capricious because they can drive wedges in long-term, really decent relationships. And that's one of the tragedies, isn't it? And staying with a person when they have one of these episodes can sometimes be one of the most affirming experiences the person might have. So we're going to move over to bipolar disorder. We all know kind of what bipolar disorder is. Years ago, it was called manic depressive illness. A person has mood cycles. It used to be thought that people had approximately the same number of manic up episodes as they did depressed episodes. Turns out that's not true. Most people with bipolar disorder have way more depressed episodes than they have manic episodes. And the depression of bipolar disorder, bipolar depression, is miserable. Worse than unipolar depression for the most part. So we've probably all met somebody who's manic. They're activated. They got way too much energy. They don't really need much sleep, little or no. Communication is speeded up, talk, or however they communicate. Their signing speeds up so fast you don't know what they're saying. Person's euphoric, and it's really quite magnetic when a person is at a certain stage of euphoria. People are just drawn to them. They're so charismatic. They're so just filled with happiness and euphoria. There's a caveat for dysphoric mania that we'll talk about in a minute. They feel quite grandiose, and it shows itself in terms of way magnified entitlement or way magnified belief in their own skills, capabilities, and accomplishments. Often people are hypersexual. They think they have special magic powers that they don't usually have. And they get kind of reckless. Marriages, money, businesses, spending, what have you. The rest of it is the typical disclaimers: not due to a medication, not due to drugs of abuse, not due to drugs that can trigger a manic episode. And the most common medicines that can trigger a manic episode are steroids and also antidepressants in people that have bipolar disorder. Sometimes when a person presents as depressed, a person will treat them with antidepressants, understandably. But if they in fact have bipolar disorder, that often can trigger a manic episode, which can be quite startling to a person who's never done that before. There's some biomedical problems that can trigger a manic episode. Lupus affecting the brain, lupus cerebritis. Cushing's disease, which is a hormone problem. and a few others. Neurosyphilis is one of the more impressive options in terms of illnesses that can trigger a manic episode. Many times people haven't seen it coming because syphilis is one of those conditions that can be lying low in a person's body for decades and suddenly manifest in terms of manic behavior. And chronic infection of the brain with Lyme disease can produce a manic episode. We all know who this is. Sad situation. Carrie Fisher, Princess Leia, who had bipolar disorder, also had a wee bit of trouble with certain chemicals, and sadly died on an airplane at 60-something years old. She had bipolar disorder, and many people believe that she self-medicated with a combination of suppressants when she was manic and stimulants when she was depressed. Very sad. Really, really talented. And what is the other side of bipolar disorder? The manic episodes are dramatic, may not be the most lethal part. It says, now that I've swung back to depression, I'm truly sorry for what I did when I was manic. And sure enough, people do end up with some regrets, right? But probably even harder is the depressed phase. All I ask is that I never feel like myself again. The depressed phase is deeper than unipolar depression, occurs more often than the manic phase, like I mentioned before. And the use of antidepressants is controversial. Most people feel like you're taking a big risk of triggering a manic episode. Other people say, well, you got to do something to lift the person out of depression. Probably the most complex part of bipolar disorder is the mixed phase. Very hard to treat. Person has some of the characteristics of a manic phase, typically sleep problems, recklessness, anger, irritability, difficulty engaging on topic, but they may have more of the mood issues of a depressed phase, grouchy, grumpy, hopeless, irritable, pushing people away. Very hard to treat because whatever you use, it's likely to make part of it worse. So sometimes when we're working with psychiatrists who are trying to help a person through this, we'll see some really, really interesting medicines be offered, but it's typically probably well thought out. Dysphoric mania, I think, is one of the most dangerous psychiatric symptoms that we have. Person has all the energy of a manic phase. They have all the feelings of entitlement and grandiosity of a manic phase, but they have severe depression. So their hatred of themselves is magnified to manic proportions. They aren't just kind of scum of the earth. They are the ultimate demon spawn scum of the earth. They shouldn't just die, they should be mutilated to death. And this is a very, very high risk time. People have all the energy to carry out every terrible idea that passes through their mind, and they have none of the inhibitions that stop them. So if I see somebody who's in dysphoric mania, I consider that the kind of emergency where a person should not be left alone. And they should obviously receive support and treatment. Remember who this is? Again, this is before we had medicines really to treat people with bipolar disorder, but this unbelievably talented and brilliant man, Alvin Ailey, had bipolar disorder, and he had prominent dysphoric mania, which earned him all kinds of reputation that he probably didn't deserve, except for the good parts. What is grandiosity and why is it important? The reason grandiosity is important is that if a person has a puffed up belief in what they've done or what they can do, they may end up trying to do things that are very, very dangerous because they don't realize they can't. The jumping off the building example is the one I've mentioned a couple of times, but we can think of many, many others. People feeling like they got such swagger that they can walk around in the most dangerous places at night without anybody near them and without any way to get help. Or they can drink a quart of tequila and it's not going to be a big deal. Grandiosity can cause people to do some pretty dangerous, reckless things. And it's part of the reason why when people have that particular symptom, it requires delicate handling, and it's pretty important, again, not to leave a person alone. Everyday ways to help: a regular lifestyle. Combined with a regular lifestyle. Combined with a regular lifestyle. Those are the most important parts of non-medicine management of the lives of people with bipolar disorder. The reason for that is that there's a phenomenon in the brain called kindling, where in people with the bipolar tendency, there's a lot of simmering activation of the mood centers present at all times. So it doesn't take much to touch off the fire. The relaxed state, the brain relaxed state, almost never happens to people with bipolar disorder. 8 or more uninterrupted hours of sleep per night. No noisy roommate, no getting up for meds, no getting up to the toilet, no night shifts, no other interruptions. It's harder than it sounds, isn't it? But it's essential. Really like to encourage people to keep the recreational chemicals and intoxicants to modest levels. If the person needs to change, it's important that their change in recreational chemicals occur gradually. Sudden sobriety can trigger a flare of bipolar disorder. So as much as we really like to get people clean and sober as quick as possible, in fact, a gradual taper of whatever it is they're misusing might be safer from a psychiatric standpoint if they have bipolar disorder. Medications. For people with IDD who have bipolar disorder, we typically focus on anti-epileptic medications. The one that has the FDA approval is Tegretol, but most of the others work pretty well. And we tend not to use much lithium just because lithium is a little harder to use, a little more likely to be toxic, a little harder to monitor. But it's not unheard of either. Lithium can be a very effective medicine. Off-label agents include certain heart medicines, calcium channel blockers, high-dose Buspar, or even for some people, Wellbutrin. Another area of controversy is the use of antipsychotic medication. As you recall, long-term use of antipsychotic medication can be hard on people from the standpoint of permanent neurological injury. Well, on the other hand, starting and stopping can be hard on people too. On the other hand, people yet tend not to like the side effects. How many hands is that? Have I got 3 hands now? On the other hand, we like to see people on as little of that class of medicines as possible. For the most part, if possible, the person with bipolar disorder should only receive antipsychotic medications, olanzapine, Risperdal, when they have psychosis, hallucinations, or delusions, to relieve those. And when those are gone and the mood is stable, we want the antipsychotic medications to go away. It's not how it happens sometimes in practice, but that is the best practice goal. Iron Man, right? He's been pretty public about the fact that his life was not very good until he got treatment for bipolar disorder and a few other issues as well. Robert Downey Jr. Compounding factors that influence the lives of people with bipolar disorder. Medication adherence is a thing because being hypomanic, right before you get to be manic, that hypomanic phase, that sweet spot, feels wonderful. It's one of the reasons people sometimes pull back on their meds a little. Well, I'll just skip it for a couple of days. Maybe I can get up to hypomanic and then start my meds again. Except it doesn't work that way. Once people get to this level of activation, they're typically headed for a manic episode and all that follows, which is not good. What are some other compounding factors? This gal is from Somalia, and she's a victim of war crimes in Somalia. And when she came over to be treated, every symptom she had was being treated as though it was related to her experience of enduring war crimes in Somalia. Further complicated because there weren't that many Somali interpreters in the clinic for a while. Further complicated by the fact that she had tuberculosis, and when she finally got treated for it, one of the medicines used to treat causes manic episodes. Finally, after all that was cleared away, it turned out, in addition to post-traumatic stress disorder and intellectual disability, she had bipolar disorder and seizures. So luckily, I think, one medicine was all that was needed to relieve all of her symptoms and stabilize her mood. What is it like to have hallucinations? Like I mentioned before, people talk about it like it's a dreamlike state. Those of you that have had hallucinations for whatever reason, chemically induced or what have you, maybe share with other people what that experience is like, because I think it's baffling. One of the questions I hear from people who've never had a hallucination or don't really understand them say, well, how could you know it's not real? And that is, to me, one of the most stressful parts of having schizophrenia, because sometimes you can't know if what you're seeing and thinking and feeling and hearing is real or not. And how often have we known somebody with schizophrenia that will reach out and say, are you real? Because of the way this illness tortures people. Kindling is a phenomenon I just discussed a minute ago. It's a central neurological finding in persons with bipolar disorder. And it's another way to look at it, it's kind of like a capacitor that's fully charged and fires more frequently than it should, and never is unpowered. Another highly functional person with bipolar disorder, starting from the time way before we had mood stabilizers, right? Patty Duke, wonderful, outspoken advocate for proper treatment, assessment and treatment. How do you know if what you believe is a delusion? Is what you believe consistent with your culture? Does it provide a helpful context for your life? Is it physically possible for a person with your body? Is it open for discussion? These are some of the ways that we can help a person talk through beliefs that they're worried. Is this delusion? Is this the truth? Is this just what I feel? What is this? Another question that comes up is, how do you distinguish between psychosis and authentic religious spiritual experience? And this is something that's been written about by people that are way, way more scholarly than I am. And what they say is that the biggest difference is that beliefs that are part of hallucinations and delusions are isolating, whereas beliefs that are part of authentic spiritual or religious experience cause people to feel a sense of connection with the world around them, a better connection with other people, and a more peaceful way of living their life. And they believe those are some ways to make those distinctions. It's a far cry from the old days when psychiatrists thought that all religion was psychosis. We know better now, thankfully. Types of psychosis that are more common in bipolar disorder. Erotomanic delusion. This is the person who believes themselves to be in a romantic sexual relationship with somebody they never met. The person believes that they are God or Jesus or Muhammad or somebody else of that stature. Intermittent belief in extreme magic powers. One fella, he believed when he was manic that all he had to do was touch the grass and that would heal the earth. I wish it was true. And pathological entitlement. People that believe that they are entitled to anything they want, anytime. Now, if people think that way all the time, that's something else. But if people believe that intermittently, along with some other mood symptoms, then it may be part of bipolar disorder. How about another highly successful person in the years before there were medicines? Anybody recognize this gal? Right? Vivian Lee, Gone with the Wind. Just a remarkably successful, but mercurial was one of the ways that she was described. What happens when you argue with a person with paranoia? The short answer is nothing good. Why is it some people vigorously refuse to release their delusions? Well, for some people, it's because there's something even worse that they'd have to believe if they did. One lady I worked with, she had this fixed delusion that her husband was cheating on her with every different person you could imagine. Men, women, farm animals, you name it. But for her to release that delusion, she had to realize that her husband just wasn't interested in her. There was nobody trying to take him away. He just didn't care about her, which was the truth. So the delusion was better. There's another reason why some people refuse to release delusions, and that is if they are wildly creative and brilliant, a lot of what they think turns out to be new to the world and true. And if you have bipolar disorder, you can't always know right away which ones of those ideas are just your brilliance and the truth, and which ones are psychosis. And this, as you probably know, is Sir Isaac Newton, who definitely had a few creative new ideas in his life. He also had bipolar disorder. Some other details. 15 to 20% of people with bipolar disorder develop dementia, typically as a result of the ill-advised things that happen while they're manic. An understanding partner makes all the difference. There's an ancient article from the 1970s called Playing the Manic Game, which talks about how people who are manic are especially skilled at pushing people's buttons, getting under their skin, saying the thing designed to enrage other people. And expansiveness, that expansive part of being manic, can make people pretty magnetic. And I think that, we all know about this poor man. Probably a really talented, decent human being, but oh my goodness, bipolar disorder has really smacked him around, hasn't it? So in summary, people with schizophrenia and bipolar disorder often suffer terribly. They can also offer the world new ideas and innovative ways to look at old ideas. And they succeed, for the most part, with the right situation and supports. And in the words of the immortal Frank Sinatra. Being an 18-carat manic depressive and having lived a life of violent emotional contradictions, I have an overacute capacity for sadness as well as elation. What an amazing perspective, and one that can teach us all. Thank you very much for participating.